Good afternoon, ladies and gentlemen. Our webinar is beginning. Uh, Welcome. We're delighted you're with us today. I'm Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council, and we want to thank you for joining us for this educational webinar. And it's hosted in coordination with Forvis, who's an associate member of the Dallas-Fort Worth Hospital Council. Today's topic is hospital strategies for preventing and managing insurance denials. And I know this has been a big problem for a lot of hospitals, not only here in North Texas, but throughout the country. This really should be a great discussion. Insurance denials, as I've just said, have impacted operational, financial, and the performance overall, impacting not only the hospital, but the patient's experience. We have a group of hospital leaders, clinical and legal experts to discuss insurance denials, and they have some strategies that they're going to suggest to prevent and resolve denials. Ryan Rozwat, Director of Revenue Cycle Performance with Forvis, is going to be with us today. Madison Andrews, a registered nurse, certified case manager, and director of case management at Stillwater Medical Center, an outstanding facility, as you know, in Oklahoma. Valorie Clouse, who's an AG nurse practitioner, family nurse practitioner, certified case manager, and director of clinical revenue cycle performance improvement, also from Forvis. And we've got Liz uh, Elias, who's the managing partner at Hall Renda. And just so you know, Hall Renda is also an associate member of the Hospital Council and one of our presenting sponsors year round, as is Forvis. So we got a great panel. We have some excellent turnout today, one of the largest attended webinars we've hosted. And we really appreciate Forvis and Hall Renda for taking the time to have this today as they're valued friends of the Hospital Council. Now, before we begin, one administrative item. Please put any questions in either the chat box or the question box, and we're going to try to answer them towards the end of the presentation. So with no further ado, Ryan, I'm going to turn it over to you.
Yeah, thank you, Chris, and excellent introduction. I'm excited to discuss this topic and have a fantastic lineup of experts with us today. Denials, Valorie and I do a ton of work in this area, really have seen the impact to hospital organizations. So even over the last 5 years or so, I'd say we've seen a 20 to 30% increase across the board in denial rates. So previously may have been in that 8 to 10% of claims denied. Now you're up to 12 to 15%, and that's just on average. So creating a lot of rework costs, revenue loss for organizations. It seems to be increasing in complexity as well. If you think of all the different pre-service, post-service, and post-payment denials. So yeah, just wanted to open up with that, and I'd like to dive right in, and we'll start with some brief intros. So Ryan Rozwat, I'll be the moderator of this panel discussion. I'm a director with Forvis and one of the leaders of our revenue cycle performance improvement team. That's really my background as far as denials work. I led a denial management team at a hospital, and then the last 10 or 15 years, I've been doing performance improvement work, primarily working with patient access and business office departments, and then helped our organization design an analytics tool that we use. So that's a little on myself. I was going to hand it over to Madison to do an intro.
Hi guys, Madison Andrews. I'm happy to be here with us today. I am a registered nurse. I was previously the case management director here for Stillwater Medical, and now I currently serve as our senior revenue cycle director. And really, so Stillwater Medical, we serve north central Oklahoma, kind of draw a line between Tulsa and Oklahoma City. We're up there in the northern half, and then we serve all the way up to the Kansas border. So we're a hospital system the main campus is located in Stillwater. We have two rural emergency hospitals in Perry and Blackwell, and then about 45 different clinics, a lot of providers. We are really an integrated health system right here in rural Oklahoma, and very proud to be here. So a little bit about my background is, so I came into revenue cycle and as a case manager, as working on the post-surgical floor, and then got my feet wet within revenue cycle, learning how to be a UR nurse, and then really kind of opened my eyes into the back office business part of the hospital, and how really the link, which was the revenue cycle, to link the clinical world and the business office or operations world together. So I'm happy to talk about some of my experiences today.
I appreciate it, Madison. And then Liz, do you want to do an intro?
Sure, thank you. And thanks to the Dallas-Fort Worth Hospital Council for continuing to get this content out in front of its members. We greatly appreciate the opportunity, as well as the initiatives that you guys take with respect to education. As I said, my name is Liz Elias. I am a shareholder in the Indianapolis office of Hall Render. I focus my practice in the Medicare and Medicaid space, and I do administrative appeals all over those two payment disciplines, from cost report appeals to claims denials, some RAC appeals, kind of anything that comes down the pike with respect to needing to appeal a Medicare or Medicaid reimbursement decision. I have been involved in those types of in that type of administrative litigation.
All right, perfect. And then Valorie, do you want to round it out?
Sure. My name is Valorie Clouse. I too, with Ryan, work for Forvis. I'm a director, and my background is a little different. Mine is more that clinical space. I worked in the hospital side in UR case management, and then went and worked on the payer side, and then decided my education wasn't quite done. Went back to school, got my adult geriatric nurse practitionership, and then became dual certified in family medicine while maintaining my case management certification. So as I come to Forvis, I've been with them for about 3 years now, and have really enjoyed working with our hospital partners across the United States, and not only the middle revenue cycle, but then also pairing with Ryan and working in this denial space, and really seeing what we can do in that middle revenue cycle for the preventative approach. So that way we're not reactionary, but we're more preventative in that denial space.
Yeah, thank you, Valorie. And with the introductions out of the way, thought we'd start with our first panel question here, which is, what recent efforts have you taken or seen your clients take to more effectively prevent or appeal denials? And Madison, we were thinking you would start off here and give the perspective from that hospital operational leadership standpoint.
Yeah, so here at Stillwater Medical, kind of a tactic that we're implementing and have been on the path for a little while is changing from more of a denials response type setup, and tracking it and being more of like a repository. We know these things are happening, but we're really engaging in our teams and making a shift to the prevention side. So setting our teams up to know the data behind it, what do these look like, instead of just kind of one by one. And so we've taken an approach to really kind of break it down into denials prevention, into all the different areas that denials can come in. So we started with 3 teams. So the inpatient team, the coding and billing team, and then the patient access. So covering all areas within the revenue cycle and all those different areas, looking hospital and clinics. And so this gives us a much different picture than kind of what we had taken, our steps that we had taken in the past. So it's also really allowed us to look at the why, the root cause, instead of just getting kind of like they feel like they're coming in every day and we can't get our arms around them. This gives us a higher level view by looking into the root cause to lead to resolution, instead of maybe getting caught in the volume. We're sure that's important. We want to look at high dollar, we can look at high volume, we can look at a mix of both, and then we can really trend it out. That's something that we didn't previously have before. Another piece in our eyes have been opened is on the impact of the front end of the revenue cycle. So the patient access, the getting the eligibility and benefits correct, knowing that this is the patient's phone number and their address and the payer, and those really, really are important. So we've worked steps that way all the way through, brings us the mid-rev cycle to like our patient statusing in the hospital. And we have emphasized getting the appropriate pre-authorizations for procedures, and then making sure those statuses are still accurate post-procedure when the patient comes up to the floor. So we've made tremendous work there, still work to be done, but proud of our progress.
Perfect. Yeah, Madison, I would agree. So if I'm summarizing, it's really semi-recently developing that denial prevention response and approach, where historically it may have been more, let's tackle this appeal, but really having a comprehensive cross-departmental approach to looking at data and avoiding it. And then also, like you mentioned, some specific initiatives that came out of that, including patient statusing. Liz, do you want to talk a little bit about any recent efforts, especially around the area you're involved with, which is on the appeal side?
Sure, thank you. Madison set it up really nicely. It's great to hear that her organization is able to take more of a holistic kind of prospective view of things and use some of the data to their benefit on a go-forward basis. It's really nice to hear that. That also, if you have the ability to take an opportunity to look at your data, it can help you establish templates for future responses, and getting a good template in place can save a lot of effort, a lot of time. We work a lot with clients on helping them kind of identify common threads, common issues, and helping them set up some templates that lead them to future success, so that they're not having to reinvent the wheel each time. But even if you're in a more reactive position, if you're not able and don't have the manpower to be able to just devote resources to sort of that forward thinking approach, just even as simple as, as we continue to have people that work remotely, just making sure that somebody is empowered and assigned every day to looking through the mail, because on my side of the aisle and the government reimbursement, there is still a lot of mail that's being sent for these types of denials. And if nobody's processing the mail in all of the departments where those letters could land, and it's a multitude of departments depending on how who's sending correspondence to where, just making sure that something as simple as getting the mail, getting it processed, getting it scanned to people, making sure that those deadlines are tracked immediately upon them coming in, just things as simple as that can go a long way to helping improve the process and improve the responses overall.
I completely agree, Liz, especially on the mail component. It's like you put all this work and effort in, and it may just be as simple as we're not getting these letters scanned in so that they're viewable, they're work timely and tracked.
Yeah.
Valorie, any other kind of trends or thoughts on this question?
Yeah, just kind of in a broader picture, it kind of connects the dots between just what Madison said and what Liz just shared with us. As we're out there talking with our clients, just really helping our clients understand those payer trends. Sometimes, as what both of them has shared, that the hospitals might be more in a responsive where they're treating each as a one-off. And so when you really take the time to track it, trend it, get that root cause established, it really helps look where in that continuum from the front end of the revenue cycle through the back, understanding, are we connected in the middle? We may be setting it up and teeing it off correctly in that authorization space, but then as we're moving down the conveyor belt, if you think of it in that space, are we having any processes that are maybe not mitigating that risk and are setting us up for failure at the end when that claim is ready to come through? Is our documentation supporting that authorization process or that level of care? But then also looking at that payer response, like what Liz had said, that mail is still coming. Those payers are still sending items by snail mail, should we put it that way? And where are we in our system noting that receipt? When we scan it in, is it in a space where from the front to the back end of the revenue cycle, they can see that we have something from that payer? A lot of times there is a break in that communication line. So making sure that it's transparent from the front to the back of the revenue cycle is really, really important.
Yep. Thank you, Valerie, and well
Yeah.
said. So I think that brings us to the next panel question, which is what major cultural changes or obstacles did you or the clients you work with face when preventing or appealing denials? Any insights or lessons learned and how these were addressed, kind of recommendations for others? I know we have various different ways that we either help or work on denials. To me, it always feels like you have a strong understanding of denials and then the payers change a process, or you're constantly iterating how you're approaching and tackling denials. So Madison, do you want to shine some light into kind of some insights, lessons learned, kind of what challenges Stillwater faced specifically?
Yeah, so something that when I think of this question, kind of this is how we've always done it, or this is how we've always handled things. And I'm going to speak from maybe a UR case management standpoint here is when we think about even 4 years ago, I would say the volume of our peer-to-peer opportunities among payers was much lower. And so really in 21 and 22 and 23 and climbing, we've seen that skyrocket. So we've seen increase in denials, but also increase in the opportunities for payer offering peer-to-peer or wanting to talk about the status in the hospital, dispute it essentially. And so something that I had to kind of challenge culturally within our organization was capitalizing on those peer-to-peers. So there was a time when peer-to-peers would come in and we weren't very familiar with them, or the game of the payer, if you will. And I think we missed some opportunity. And so then when we really got to looking at the payer behavior and realizing, hey, this stack is growing, then we were able to get a strategy and a plan to kind of excuse me, moved forward to like not missing a peer-to-peer. So I look at where we were several years ago and then where we're at now, and it's just an understood. We know they're coming, we're ready, and we take action and capitalize on that. So for our organization, that was a big deal. There was, I think, 2 years in a row where we overturned between 76 and 80% of our peer-to-peers. So that is, that's incredible. So that they were able to be overturned from streaming that through our hospitalist, our internal physician advisor, or we used an external physician advisor on some of those too. But that was, we kind of pushed back on read between the lines on those denial letters. Like every denial letter looks different. Every peer-to-peer timeline is different, and how you have to go about it. And so we became, I would say, better equipped with kind of having that diversity, external physician advisor, internal. And then if we had to, we had to ask the team here. So that was a big one. And that really just helped kind of lead into all of our prevention efforts, I would say.
Yep, that makes sense, and appreciate the insight there. Liz, any thoughts on this question from kind of that appeal standpoint, some of the clients that you work with?
Yeah, sure. I don't disagree with Madison's assessment that it's, it's hard to change people and to change workflows that have been in place for a long time, but this is a constantly evolving world that needs constant revision, constant attention, constant research, constant learning. And you just have to make sure that your appeal letters that you're drafting are responsive to the requirements for medical necessity, or the check marks that you have to have in the chart for a pacemaker, or whatever the case may be, that all of your documentation is in good order. and that it's thorough to speak to the need for whatever, whatever service was provided. The most successful examples often have a really involved physician advisor. That can really be a key component to the success of a lot of a good appeal letter, is that you have a physician go through and just say, yeah, that might say that in the chart, but really that tells you X, Y, and Z, and help provide a little bit of that color, add some of that color and translation, particularly if it's new technology. If it's new technology, you really need somebody who is more familiar with that new technology to be able to opine and make sure that everything reads correctly, and is keeping with the updated language and procedures there.
Yeah, very well said. That brings us to Valorie. Is anything else
Sure.
to add there, as just as far as global trends
Yeah.
or what you're
Yeah,
seeing?
well, I think just to tie it all together, there's a couple different, things that we have seen from our clients, but then also tying in, Liz and Madison's to essentially our clients as a whole, or what we're seeing across the United States. There's sometimes misinformation at the executive level, where without data, that tracking and trending, there's a lot of assumptions. Like such as statements that we've heard that, the denials are being caused all by one department, or the whole problem is documentation. And so, with sharing what, taking with what Liz has shared and Madison has shared, it really needs to be tied together. And from what we're seeing, it's typically not just one department that is driving denials. And so by starting out and getting leadership buy-in, getting good processes in place to avoid that denials process and understanding that period of time for response, but then also getting cross-departmental collaboration. Again, rolling back into that root cause, understanding where it spans across the departments, and then accountability. A lot of times we can root cause, but then trying to get the ownership to hardwire that improvement can be challenging. So within that organization, find the stakeholders and those who are going to be holding themselves and the organization accountable when, as a consultant, we are stepping back. And then the continuous improvement mindset. And as Madison has spoke, Stillwater is obviously in that process, always looking to see, hey, what can we do better? How can we, make sure that we are responsive to the payer, but then also understanding the standard processes to hardwire it in for their organization. So I guess, leadership buy-in, collaboration across those departments, accountability, and then also continuous improvement mindset is really important.
Well said, Valorie, and I would echo that, especially on the department cross collaboration side. And I know a lot of these initiatives, it can feel like you're pointing the blame at one department or another. Typically, when we help organizations with this process, there's opportunity in every area of the revenue cycle or within the operational process flow. So it's, hey, how can we individually improve the overall process, reduce denials, and identify the issues. So
True.
That'll bring us to the next panel question we have here, kind of expands maybe a little more detailed, which is, what are some of the top clinical issues you have encountered contributing to denials for your organization or the clients that you've worked with? How have you addressed them? I know we have Valorie, yourself with the clinical operations background, care management background. Same with you, Madison. So, and then Liz, if you want to kick us off here, provide your insight there. Thoughts to this question?
Sure. I'm not really sure that I have a pattern or a couple of top things that I see come across my desk. It really is hit or miss. The one thing that, the one common thread that always seems to be pulled is just garden variety medical necessity, just challenging the medical necessity of the stay. And I think that, some of the solutions there are pretty simple. Oftentimes, and I'm not a clinician, obviously, I went to law school to sort of avoid having to go take all that biology and science. But I always encourage people, like, when you're putting an appeal packet together, are you putting in documentation that somebody like me could read and understand what they're saying? because while sometimes those reviewers at those or at the organizations contracted by the government payers have that knowledge, sometimes the depth of that knowledge, particularly as it relates to newer technology, because they might have been out of clinical practice, active clinical practice for some period of time, it's really important. And then, another just simple tactic when it comes to medical necessity is that you get a request for records, and it says a date of service, but when it comes to medical necessity, that might have been established in some piece of prior imaging, a prior visit, something that happened way before the date of service that's being questioned. And it's really important to make sure that your appeal paperwork contains those pieces of the chart that helped establish, and not just, don't rely on the H&P, because that doesn't always paint the complete picture of why somebody's sitting there today, or why they presented for a particular service. You often have to go back and pull imaging or pull referral notes or pull reports from other physicians to help paint the picture of medical necessity. So that's what I always encourage you, or encourage providers that we work with, just to make sure that the entire picture is painted. And if you need to draft an appeal letter that translates some of that, then translate it, right? Because sometimes the clinical notes that are put in don't always make sense to us, but then you'll get the attorney advice or the physician advisor on the phone. They're like, of course that means of course that's what I meant to say, right? Like, I'm like, I don't know that. And you have to assume that the judge that we're ultimately going to be in front of doesn't know that number is way out of whack, right? There has to be some translation for the best chances of success, such that a lay person like myself or an ALJ can understand it.
Yeah, great response, Liz. And that really resonates with myself is, hey, if we can use plain language, English, let's have that resonate. I mean, the goal is to improve your appeal rate, not prove that you're the smartest person in the room or can draft the most clinically relevant or kind of show your expertise.
That's right.
Madison, how about your thoughts kind of on this question and what you're seeing at Stillwater?
Yeah, so Liz teed it up. I would certainly echo the referral to the specialist, right? Like, I'm thinking of sleep medicine or something, where they get the referral, and sure, the patient needs a sleep study and this and that, but the documentation, the reason, all the diagnosis, it's not in the visit maybe at the sleep medicine clinic, or the PCP visit maybe from last month, or we all know that there's like time frames. I mean, it doesn't have to be the most recent visit that this is documented on. And so that, I think we hear that within our system is because we have PCP and specialists is, and we are also seeing it on our denials prevention teams, where we're getting denials for sleep studies, just as an example, and other things, because the beef of the documentation wasn't in just that visit. And it takes a collaborative team across the revenue cycle to dig and find the team of people that we have working appeals and we have them in revenue integrity here at Stillwater Medical, but they are savvy. I mean, it's they're not RNs, but they know the medical record front and back, and dig within different charts to find just what they're looking for. So plain language, but also, something, you don't want to send the whole 800 pages with your appeal letter. You need the pertinent information to send to the payer to substantiate the reason why the patient's getting care. So that, I couldn't agree more, Liz. I would say a couple other different perspectives that I have in just working in our denials prevention team is, so for example, on our inpatient committee, we pulled our data showed, we kind of pulled by top payers, high dollar, high volume, and we were looking at payer behavior specifically. And they came across like medical necessity denial. So we're thinking, okay, we need to get back into our documentation. Let's tie it to a diagnosis. But what we really found after trending it out a few months is some payer behavior that is sort of disguised like a medical necessity denial or a clinical denial, if you will. But when you really get into it, it's got the 252 reason code on there, and it's requesting additional records. Well, they're not full denials, like we're getting payment. And so what we were able to kind of figure out is we really think those are leading to some DRG validations, not necessarily like a full medical necessity case like denial. And so we have been able to appeal a lot of our DRG downgrades and appeals. We, with one payer, we set, based on their guidelines, they have like a physician meeting. Their medical director comes in, we can bring our coding team experts and our physician advisor, and we can talk about it right there. So DRG appeals, it can happen in a lot of different areas. Sepsis, I'm sure our organization is like many others that we are all debating on if it's sepsis 1 or 2 or sepsis 2 or 3. And so that's something that we saw. But really, I would just, I guess a piece of advice is if you can get into the weeds of your denial data, like we thought, oh my gosh, what is our clinical denials? And we really found there's more technical denials. So we're proud of that, right? Like we're proud that we have good documentation, and maybe we're being DRG validated. But that's something kind of at the surface level, and we would not, I really think that we would, it'd be very, very challenging to prove that if we weren't tracking and trending focused on prevention.
Yeah. Well said, Madison. And Valorie, any other thoughts?
Well, as we're looking at those as a whole, just kind of keeping in mind, and Liz and Madison both touched on it, is when we're talking about claims and we're talking about, as Madison had shared, we look at the CARC and RARC codes, and just kind of think of this denials process as in the clinical space, throwing my clinician hat on. When we're looking at it from a coder space, we understand that there's adjudication logic, and that has evolved quite a bit. And we've got scrubbers and we've got items within our electronic tools to manage that for us. But when it comes to this clinical aspect, like what Madison said, looking at it differently, being able to gain an understanding of what those rules are that are driving those clinically based denials, and understanding how they may come back looking at as one item, but then as you root cause it, it's actually a totally different animal. And understanding that the payers, they even have some issues themselves with understanding, here we have the authorization process happening maybe to a vendor, to the payer, and now we have the claims being processed, and another vendor might be saying, hey, we don't have the documentation. Well, it was gathered by your other vendor, it just didn't come through. And I see Madison smiling on that one. That was, the right hand didn't know what the left hand was doing. So understanding that, if you have a full view inside your organization of that process, it'll help you with those conversations with your payers.
And I just thought of one other thing, if it's okay
Sure.
to chime in here. So thinking about just another way that our team has been able to kind of carry this across different departments would be, if we take this data. So I'm thinking DRG downgrades, for example. So you think, okay, how do you let your physicians know? What do we do about this? Like, what action do we take? And so something that we do at our organization is myself and the coding director is very involved in our utilization review committee. And so that is a way that we can get our medical director and hospitalist and different specialty groups, as well as our physician advisor, kind of keep them in tune by presenting the data. And it's tying the physicians who are taking care of our patients and doing the documentation. It's helping them have a true tie and insight to the data that we're presenting through UR. And And then we use it as an education platform. So the first few slides of our UR committee, our CDI and coding team takes that opportunity as kind of like a focus, or we're seeing this, here's the data, here's some education to go with it. And then the physicians they instantly start talking about it and they take it back to their peers, as well as we have our CDI team who travels to different, the monthly physician groups to present kind of on the same topic. And then we pick another one and go from there. So just maybe a tip from our side I wanted to share.
Yep. Perfect.
Thank you.
Very well said. And any other thoughts from the panel, or we might be ready to move to the next question here, which is, what recent trends are you seeing when it comes to denials or appeals, kind of cases your clients are reaching out for support on or you're working on? And I'm actually going to partner with Valorie here and provide some trends that we're seeing in the denial space. And I'll speak more nationally, kind of at large, what we're seeing. And I mentioned at the very beginning is just the increase in the denial rate and complexity of denials. So again, where we typically saw more 8 to 10% denial rate in the past, 8 to 12, that's getting closer to that 15% mark and it seems to be increasing year over year. So we're reviewing research that suggests that as well. So increasing complexity, increased timeline to receive payment. So even if just having the payers process the claim, that typically was a 15 to 30-day window from getting the claim out the door to payment. Now that's airing more on the 45 to 60-day time frame. A few other trends we're seeing within denials, payer trends, increased requests for information. So that is the top denial reason, often comes through as that CO16. At a national level, that's 16% across the board of the national total. If you look at, hey, 100% of your denials, almost 20% of them are related to requests for information. And then another one would be front-end preventable. And again, more of a global, but about a third of the denial reasons, if you look at them, authorization, registration, coordination of benefits, eligibility being terminated, those equate to roughly a third of that total. So an area that we see a lot of opportunity in on the outpatient side, really honing, increasing the efficiency of your financial clearance team, especially for those high dollar outpatient services, and then obviously inpatient services as well. So that's a little bit at the higher level. Val, any thoughts on analytics or trends or what you're seeing, especially more in that clinic space?
Well, in the clinic space, Ryan, you and I are often asked inpatient, outpatient denials, they're all the same, right? And I think that's where we can definitely have some, some information to share with the folks today is that, inpatient denials, they're most often what we're seeing in a trend is that their factor is both in volume as well as discrepancies in ordering processes and maybe variations in services as far as are they actually performed as well as they're being at the right place where the test should be completed. However, once we get to that inpatient denial space, it's a whole other complicated animal. You've got the admission management, you've got utilization management, you've got your review processes, both on the organization side and the payer side. And then it's even complicated further by your varying lengths of stay and your levels of service. So inpatient and outpatient are both very different in terms from what we're seeing on a state and a national side. But then also the causes and what causes the denials are, relative to the inpatient or the outpatient services, the top pain points, we should be tracking those as an organization and understand from a perspective of the providers. I can speak from a provider standpoint. I would just keep doing the same process over and over again unless somebody said, hey, Val, your documentation isn't supporting this item. We're getting denials. So making sure that when we are responsive to these denials, that we're sharing that information back into the the provider standpoint to help them correct either processes or their documentation. And then understanding location of service. We may be providing the level of service at the wrong location. So understanding your payer contracts.
Yep. Well said, Valorie. And I know we talked through this question a little bit and say, are we seeing specific trends with payers, reasons? It's difficult. It doesn't seem like there is any consistent trend for a long period of time. It would make our jobs a lot easier if it was,
Sure
hey, it's
would.
only Blue Cross that denies and it's only for these 3 denial reasons, but it does
Yeah.
seem to change. I know I referred to it as a game and didn't mean to be any slight at the payers by saying that, but it kind of feels like that because there's different reasons and different trends that seem to pop up.
No, and
Time.
piggybacking on
Yeah.
that, Ryan, what we're seeing in that trended space is that some of the organizations are choosing to then become out of network for some of these payers, or
Yeah.
are in litigation with the payers currently. So that has become something we're seeing a little bit more often as we're entering new engagements with clients. It's actually become part of my interview question. Do you have any current litigation with payers? Because it really helps you know just where those pain points are right off the bat.
Yep. Liz or Madison, anything to add on this question as far as recent trends that you're seeing within the denial space, either prevention or appeal?
You want to go first, Madison?
Sure. Yeah, I would just add, so I think something that I learned when we were in network with Medicare Advantage is that the payers have different timelines than the hospitals operate by, right? And that hospitals use, so I'm speaking purely from an inpatient focus here, but we you use certain interqual or certain criteria for like MCG or interqual for your admissions. And so the payers are also using some sort of tool or maybe their own. And, everything gets updated each year, but all of that can happen at a different time. So something that I learned was if you're tracking your like top peer-to-peer options or denials from the payers by diagnosis, then you can say, okay, we keep getting peer-to-peer offers, for example, heart failure. Like, why is this? And you can dive into that. So something that that we did was we looked at that and we thought, okay, we made some changes and some improvement, and then we saw a decrease in preliminary denials and even peer-to-peer offerings because we had kind of picked up on a piece of the game, if you will. And so then about, I think it was for us, it was in June. So, came out of the blue second quarter. Well, here it's something else spiked. And so we thought, man, we just had a handle on this. What happened? Well, at the time we were leveraging our payer relationships between our UR team and case management team and having set calls, which if you have the opportunity of that, I think that's very helpful to make a relationship with them, because again, just like Liz or Val said, that everybody's operating at different timelines and you get to know different, the people who process your hospital's information, but if they're out, maybe a different district is processing it and it's different. So it could look different to your frontline team taking care of that. So those relationships were really helpful to lean on. But I had them look at it with me and said, what is up with this? And it came out that the payer had changed their criteria in June. And so sure enough, that is when we saw like a spike on something that we, previously had a handle on. So it just goes back to the folks doing this, the frontline team, just making sure that they have support to somebody keep a big picture view on this to spot the trends. The trends are there, and you can learn from your payer behavior. So that was all I was gonna add.
Yeah, I think that there's some good lessons in what both Madison and Val have said. With respect to trends, because I work mostly in the Medicare and Medicaid space, the sort of age-old adage that if you're billing certain codes at an aberrant rate compared to your peers in the area, that is always going to cause a red flag to go up and will probably result in you being audited for at least a sample of claims at some point. It's difficult to understand kind of how you measure up with your volume compared to other people in the area, but I keep going back to new technology because that does seem to be a frequent source of appeal work for me on the claim side, is that there just isn't, it's new to everybody. And so the reviewers may not have a good process in place to review those things as well. I'll get on my soapbox about criteria as it relates to inpatient work, and Val knows that this is a pain point of mine in particular, that the government payers really should not be using that type of criteria at any of them, Interqual, NCG, any of them that exist, unless they have affirmatively disclosed their intention to use that type of criteria. We see time and time again reviewers that are using criteria with no prior notice. They're not using correct versions. They're applying, adult criteria to peds cases. There's all kinds of sort of missteps in the use of evaluative criteria. I also think it's problematic from a more substantive standpoint, because that's just a very subjective process to review against criteria. It's often being done by non-physicians. And so, to sort of step in the shoes of a physician that made an admission decision based on a number of set of circumstances, often which can't be baked into that criteria that's being evaluated, is something that really should be fought by your organizations. Anytime you're getting any of those types of reviews against criteria, I think that's always worth looking at and considering whether an appeal, whether there's merit for an appeal. Just a note as it relates to Medicare Advantage, because that seems to be kind of a bubbling issue. They have gotten a lot of power in some places with respect to denials of, a lot of times it's related to post-acute care, but it's not limited to just that. It can be a whole host of issues. There has been some recent policy making that will hopefully rein in some of that they are going to have to start using Medicare criteria where it exists, or Medicare policy. But anything with a date of service prior to those new policies should be evaluated and pushed back on. I run into this a lot because I often help hospitals with sort of global cost report appeal initiatives, or more global non-claims based appeals. The 340B payment litigation, where CMS reduced 340B payments for a couple of years, and then CMS eventually restored that payment. Well, at the same time, most of the Medicare Advantage plans also took that money and made that payment cut, and most of them have not restored that payment. And so there's opportunities there. That continues to be a pain point. I'm hopeful that will start to reduce, but I'm not confident it's really going to stop the bleed with respect to the Medicare Advantage. And there are some organizations that could just devote a whole team of a whole lot of people to doing nothing but fighting Medicare Advantage. That continues to be a significant pain point.
Yep, completely agree there. I think that brings us to the next question here. We see a lot of vendors in this space. If you think of denial prevention, management, appeals as a whole, it involves a lot of people, a lot of different types of technology. There's a lot of vendors out there offering different components, whether it be technology, analytics tools, staffing. So we're going to cover a few different ones. And questions is, how does your organization go about selecting vendors or partners to assist you with denials or prevention efforts? And what recommendations do you have for others when it comes to selecting vendors in the denial space? And I think we were going to start off with Madison to kind of talk through her process for looking at a third-party physician advisor vendor.
Yeah. So I think it's really important to, as an organization, definitely different stakeholders, to really understand what your team needs. So my example is related to physician advisor, but understanding all the way from the frontline staff to manager, director, and then senior leadership to yes, this is what we really need. And then that lets the organization select and kind of search for a vendor who really would match with kind of the alignment of the operation that within the organization. So the vendor and the organization, that they're really looking for a partner that matches the things that need to be accomplished, and really what you need, not necessarily just like, can they do this, and is it the cheapest, or is it this? And so I'm sure we've all been in these scenarios where there's been a vendor who provides this list of services per se, and then you need to, I think as an organization, it's your due diligence to really be a partner, is to validate some of those services. So my example kind of leads back to an experience I had with appeal letters. Is that was something that we had outsourced, and then our appeal rate wasn't very good. Our overturn rate wasn't very good. And so we got to looking in it a little bit more, writing some of our own and just kind of experimenting, like, how can we make a change here? And then we didn't see the I guess details, if you will, kind of like what Liz had said on the plain language, like with the appeal letter, like matching the medical information, the medical record, and then the appeal letter kind of like ties a bow on it and sends to the payer. And so, it's also frustrating when you would experience maybe timelines that would differ from what you could do internally versus externally. So I think these are all really important things to be mindful of, that not just can they do this? Yes, lots of people can say yes, but would we here at Stillwater Medical, we like to ask ourselves, like, do we feel comfortable with them representing doing this equal or better than Stillwater Medical could? And kind of hold our vendors to that higher standard, more toward partnership.
Yep. Very well said, Madison, and trying to be mindful of the clock. I know we could go on for hours talking denials. We're trying to do a wrap-up question as well, but Liz, wanted to get your thoughts on this question, and specifically on the legal support side, appeal side, kind of where you operate. I know you are a vendor, as Valorie and myself are, but kind of what are your thoughts here for what to look at when it comes to a vendor, kind of recommendations you have in the selection process?
Sure. I think you need to take a holistic look at what vendor support you're going to need as long out in the process. It's certainly great to hear that Madison has gotten somebody to help on the physician advisor side. Because they can certainly help you, depending on which organization it is, can help you all the way through the appeal process, which is great. Sometimes because of available resources, vendors aren't able to be retained until further along in the process. And I sat down at my desk this morning and first thing had an urgent email from somebody with an ALJ hearing in 2 weeks, and they want us to help them with that. The real problem, this was a Medicare issue, and the real problem is that at least with respect to Medicare appeals, your record is more or less locked before you get to the ALJ stage. The ALJ is the third stage, and really documentation is locked at the second stage unless there's some like extenuating circumstance, and deciding to hire an attorney 2 weeks out is not one of those extenuating circumstances, spoiler alert. So it's difficult. I'm candid when I get those calls, and I get them frequently, that I may not be able to help you as effectively as I could have if I'd been engaged and could have ensured that the documentation is at the standards I want them to be at. Certainly, I think that you need to start thinking about that sooner if you think you're going to be too nervous to do it on your own, and that you're going to want help. I also generally think that having a physician partner, whether it's an internal advisor and an external advisor, to help translate the medical record. I like to have conversations with those folks when I do have an opportunity to do an ALJ hearing, and I think that those always fare far better than instances where I'm not provided that physician support. There are also ways, just from a prospective basis, looking at sort of your overall revenue cycle function and just kind of what can you do, or where are the sort of vulnerabilities within your own system. There are ways that you can engage vendors through attorneys, and you can do all of that under attorney-client privilege. Sometimes there's some merit to that, and some people feel comfortable with that type of arrangement. It's not always necessary on these sort of post-payment denials or these types of denials. But if you're doing kind of prospective looks or more data analytics, that's certainly something that an organization could consider as one of their strategies for doing so. But again, it's just, be sort of try to think ahead as far as possible. Don't wait until the last minute to hire any vendor, regardless if it's an attorney or Forvis, or a physician advisor, because we, at the last minute, we can't be as effective as we could be. And we may just be working the best with what we have and not being able to put forth our best effort on behalf of your organization.
Yep, very well said, Liz. And Val, any other thoughts to add?
I think just to kind of tie a bow on that is, just kind of taking what Madison and Liz has said, but organizations fundamentally should look for vendors that have a combination of clinical readiness as well as administrative readiness. And they both need to work together to deliver appropriately, so that the care can be delivered to the patient, as well as be able to fight that denial engine, to be that supportive function for the organization as a whole.
Mm-hmm.
Perfect. That leads us to our last questions. I know just a few minutes here, but wanted to ask you all, what's the most important takeaway? We've covered a lot of different areas when it comes to denial prevention, appeal. If you want the audience to take away one thing, kind of what would that be? Liz, do you want to kick us off?
Yeah, it's simple. Make sure that all of your communications and your documentations are translated into plain English.
Very well said. Madison, how about yourself?
So I would say, don't be afraid to push back on the payer.
All right. Then Valorie.
Echoing what they both share, but then also understanding that in that denials process, that there is another component that we've not touched base yet on, which is the patient experience. Understanding that you may have a perfect clinical encounter at the facility or at the clinic, but then the lasting impression for that patient is a denial letter that they receive from the payer. So, keeping that space. As I cared for clients or patients in my office, I would tell them I'm taking care of them physically, but fiscally too. So as an organization, making sure you keep that mindset.
That's a great point we didn't touch too much on, but keeping the patient experience in mind through every step of the process.
Absolutely.
Absolutely.
All right. Well, we appreciate the time today. I know we're right at 3 o'clock here, but
Yeah,
wanted
Ryan.
to thank.
Yeah, we want to thank y'all. Y'all have done a great job, and on behalf of the DFW Hospital Council, I will tell you there were no questions in the question box, but I do want to tell you I speak frequently, and there's two things people have asked me that I'd like to point out, and I know y'all touched on it, but no matter what meeting I go to, state association, local or national, all I'm hearing are complaints about Medicare Advantage. And not only the pre-authorization denials, but their overall denials. There was an article yesterday in Modern Healthcare. Rural hospitals are going to end up losing all their cash flow because of Medicare Advantage. And, Elizabeth, is there anything we can do legally? I mean, this is serious stuff related to the cash flow of all hospitals, but especially rural hospitals.
Yeah, Steve, that's a good point. Thank you. Yes, there are ways. It usually involves litigation. Sometimes those Medicare Advantage contracts, though, have binding arbitration and sort of try to circumvent or get around the litigation process. But there are ways that the voices could be heard. It's generally speaking through some type of class action or through a hospital association, often taking the lead on that. The American Hospital Association's been semi-active in that space too, but certainly the voices of the individual or the regional or even the city, the municipal hospital associations, those voices are heard equally too.
Right. The other thing that I hear about, and it's probably premature and it's a little unfair, Do you see artificial intelligence in any way helping with managing claims and preventing denials?
I mean, I certainly do, because I think that eventually there will be tools that can go into the medical records, into the revenue cycle data, and pull out some of that, do some of that trending sort of automatically. I do think that there is that this might be one in area where AI could be beneficial to everybody, as that continues to be developed. Certainly, we have to worry about the cybersecurity and the security of that data, vis-a-vis the AI and, sort of introduction into the medical records vendor, or into the medical records themselves. So that's something that we are constantly monitoring, and I do think it's an area where it actually may be helpful at some point in the future.
Good. I have one final comment and a question, and I'm going to direct it to Madison. Madison Stillwater's got the best homecoming parade anywhere that I know in colleges in the nation. It's fantastic. So for any of the folks that are on that don't know that, they need to go. And my question for you, which I know is going to be difficult, Madison, the Dallas Mavericks are in Oklahoma City tonight. How many points are they going to win by?
Win by, oh man, I can't say that. I think I'd have to stay with the Thunder on that. I know that we're on a DFW call though. But yes, I'm seeing us at the America's Brightest Orange homecoming parade, October.
Great. I'm just teasing. Ryan, I will say we've been delighted to have all of you on. You've done an excellent job. I know our participants are pleased. Chris will make sure and get this out to all the people that registered. But I'll give you the final word, Ryan.
Yeah, thanks, Stephen. I appreciate the opportunity. And I think I'll end on that note. Is just, I had a really good time with this presentation. It was really, really fun to have an active, engaged discussion on preventing and managing denials. It's a topic that impacts all of our clients. So appreciate it again and look forward to the next opportunity.
Thank you. And you all
Yeah,
have a
thank
great day. We're now
Thank you.
concluding this webinar.